Hello, this is Dr. Zitao Liu. Today we're going to talk about a very new service and provide at New Hope Fertility Center, and also we're going to have our one of our panelists, Jennifer, and Jennifer is from Genomic Prediction. Today we're going to start our talk regarding PGT-P. And we will do the embryo transfer, and we have many embryos, and a lot of times, and the patient will ask us which embryo is a good option to be transferred. And a lot of times, and we can see that when we have the, we can see when we get the egg, we fertilize the egg, we create the embryo step by step, and then this is a day 3 stage embryo. And then we can cut the embryo to about the 6th stage to transfer. And at this time, and we do a lot of pre-implantation genetic testing, including PGT-A, PGT-M, and PGT-SR. And we know for this test, it just gives some option to see if the embryo have a normal number or normal structure, or if the embryo have a gene mutation. Here, and still a lot of patients have the question, they want to know if the baby have a risk to develop some chronic disease such as diabetes, hypertension because of the family history, or if they have multiple embryos, they want to pick up the best embryo for transfer. Under this situation, and from the current technology, and previously we do not have any good option. We have no good approach to answer this question. So now we have a good test called the PGT-P. And from this test, we have another good approach to help up to figure out the best embryo for transfer. Now we're going to have a video to show what's the PGT-P. Hi, Jennifer, how are you?
Good, how are you?
Good,
nice
good.
to speak with you today.
Me too, me too. I'm so sorry, I kept talking, I forgot to introduce you. Do you mind to tell the audience something about yourself?
That is okay. I'm Jennifer Eccles. I'm a genetic counselor, the head of genetic counseling at Genomic Prediction Clinical Laboratory. And I've been a genetic counselor for about 20 years, working with families trying to have a baby. And for the last couple of years, I've been working specifically with families who are undergoing the IVF process.
Awesome, awesome. And I'm very happy to have your company's new service. Do you mind to show the audience about the video about PGT-P?
Yes, let's get that going.
Oh, by the way, I also want to announce the schedule first. And today, and we're going to have some audio play, and also we're going to have some question to the audience. In the end, the audience is going to have an opportunity to have a raffle to get a service, discount in the service of PGT-P. Okay, let's play.
Thank you so much for joining our webinar today. As an introduction, we wanted to share some information about pre-implantation genetic testing in terms of what has been available for the last few years and what's new in terms of the latest developments in pre-implantation genetic testing. So what are the indications for PGT that we're more familiar with and that have been around for a while? So PGT-A stands for pre-implantation genetic testing for aneuploidy. And aneuploidy refers to the number of chromosomes in an embryo. Aneuploidy screening is designed to help improve IVF outcomes. PGT-M is screening for monogenic disorders. These are conditions that are inherited in families or conditions that occur when both members of the couple are carriers of the same genetic condition. And so if a couple is at risk for this particular type of condition, then PGT-M would be most appropriate. And then finally, PGT-SR stands for structural rearrangements. Structural rearrangements or chromosome translocations is another term. It refers to testing when one member of a couple has a change in their chromosomes that makes the likelihood of extra missing chromosome material more likely. And so these are the types of indications that most of us may have heard about or are more familiar with. Currently, there's one additional test offering that's brand new that's called LifeView. And LifeView is available through Genomic Prediction Clinical Laboratory. So what is LifeView? LifeView is screening for genetic conditions that are caused by changes in multiple genes. These conditions are known as polygenic disorders, and another name for LifeView testing is PGT-P. Examples of polygenic disorders include type 1 and type 2 diabetes, certain types of cancers, and certain types of cardiac risks. This is an example of a LifeView report, and couples have the opportunity to choose from the list of conditions that are available for screening what traits they would like to screen for. And for most of the traits, we provide the specific risk for each individual trait, and we report traits as within the normal risk range or as high risk, depending on what that particular risk is. In general, if the risk is 1.5 to 2 times the average risk, that condition will be flagged as high risk. And so we hope this gives you some additional information about LifeView testing, and we hope to continue the conversation and answer whatever questions that you may have. Oh, unmute yourself, Dr. Liu.
You hear me?
I could hear you now.
Oh, sorry. Okay, yeah.
That's okay.
And I think our audience still has some confusion about the indication for this test. And of course, we compare the difference between PGT.
You're muted again.
Oh, okay.
There we go. Sorry.
Okay, good. Okay, who is the best indicate? Who is the best candidate for this test?
That's a great question. Actually, all couples are wonderful candidates for PGT-P. Because in general, we all have a risk of having children with these conditions. So the general population for these conditions can range anywhere from less than 1%, and in some cases, conditions that are more common like heart disease or hypertension or high cholesterol, those are much, much more common. And even if we think about our own families or we think about our own health history, we either have one of those conditions ourselves or know of somebody in our family that has one of those conditions, even if it's a distant relative. That's very, very common. But even if we don't have a relative in our family with one of those conditions, we all have a background risk of developing one of those types of conditions. And we're learning the more and more we do this type of testing that we're finding out that even in families that don't have a known risk of these conditions, we're seeing people who have high risks of certain conditions because these conditions are quite common. So anybody could potentially consider this type of testing if they're going through the IVF process.
However, Jennifer, I got some feedback from the patient. For example, if for a 40-year-old lady, they only have one euploid, at this time, probably she has no other option. And so, of course, and she's very interested to know if this embryo will have a higher risk to develop all this chronic polygenic disease. However, even though she knows it, but probably she don't have any other option. But I think that for a lot of younger patients, for example, even like younger than 35-year-old or even younger than 38-year-old, they have multiple euploid to be transferred. And at this time, probably that's a good approach for the patient to have option. Or sometimes I have I have a lady about 40-year-old, but she used a donor egg and she has multiple embryos to be transferred. At this time, she can ask me which embryo is a good option for sure. And if she has a 4 to 5 euploid but she want to have one baby at this time, and for sure, and we are going to have a criteria to pick up the embryo. Previously, I always used the grading of the embryo, such as morphology grading, and also the date for the embryo to reach cyst as a criteria. I think now, if I have all these the PGT-P data, that will be another criteria for me to give a patient a good recommendation.
I totally agree. And you bring up a great point. The PGT data should be used to help triage samples and order samples to decide which embryo you're going to choose to prioritize for transfer. So certainly if you have 1 or 2 embryos, that information for you may be less important. And if you have more embryos to choose from, then that information may then, of course, be more beneficial. I totally agree. Hi, Dr.
Okay.
Jackman.
Hello.
Hi.
How are you?
I'm good. Had a little bit of technical difficulties, but I'm here now.
Okay, great. Yeah. So my next question is, if a patient wants to have this PGT-P service or the LifeView service, and she's a good candidate, how is she going to start this service?
So the first step is whenever a couple is referred for this testing, they have an appointment scheduled with me to have a detailed genetic counseling session, because in that session we review in detail the benefits and limitations of this testing. And then if a couple decides, after hearing everything from their physician and then hearing everything from me, that they would like to proceed, then we collect saliva samples from both members of the couple. And the saliva samples are used to help enhance the testing platform for us and to help provide us additional information when the biopsies are being tested. And so it's very simple for us to collect saliva samples, and then once we receive the embryo biopsies, then we run the testing, all of those samples together on the testing platform.
Awesome. So now I have 2 follow-up questions. Number 1, if a patient want to get a genetic counseling from you, of course they want to know how much you can charge them. The second is the sampling. And as you know, at the New Hope Fertility Center, we're collecting the medium to do the PGT-A. But it seems that from what I heard from you, and for your service, you have to biopsy the embryo and for the PGT-A, right?
Yes, for PGT-A, for the clinical testing that we're doing, it requires a traditional biopsy sample. In terms of the cost for genetic counseling, that's included, that's free of charge, because we feel very strongly, I feel very strongly as a genetic counselor, and Genomic Prediction feels very strongly that genetic counseling is a very important part of the whole process to make sure that all of the benefits and limitations of testing are reviewed in detail, because there are so many nuances for this testing, and it's important for couples to be able to get their questions answered and make sure you understand fully the type of information that this test can and cannot provide. And so we provide that. And if you decide at the end of the genetic counseling session that you're not interested in testing, that's certainly okay. Because that's the goal of counseling. The goal of counseling is to make sure that every couple gets the information that they need in order to make the right decisions for them. And there's no one-size-fits-all approach.
The counseling comes before the actual testing?
Yes, it does. Yes, it does.
Okay.
All right. Okay. And now, okay, and I mentioned, and at New Hope, and we have been doing biopsy to do the for the genetic test for a long time, and we are almost one of the few clinic in New York, in US, to start this service. And now we are doing the non-invasive biopsy, or we call the liquid biopsy, to collect the medium to do the genetic study for PGT-A. And of course, and we know that for your service, and you have to use a biopsy sample. And we are very happy to collaborate with your company to build up a new protocol, so that in the future, we are going to use the culture medium or the liquid biopsy to achieve this goal. And under this situation, I think any of the patient who is interested in this research, and she's welcome to join our research. And but this is another topic. And let's still go back to the PGT-P. And in general speaking, and after the patient collect the sample, and how long do they wait for the result?
The results take 2 weeks to come back, and a detailed report is issued to your doctor's office, and then you have an opportunity to review those results with your doctor. So every patient has that conversation with their physician, and then I remain available always to answer whatever questions come up after a couple receives their results.
You mean the result will send it to us first, and then if the patient still, and then we're going to update the patient, but the patient still have any concern, and they should have no problem to speak with you again.
Absolutely.
Okay, of course, and at New Hope we have a very diversity of patients. Some of the patients speak in Spanish, some patients speak in Chinese, some patients speak in Japanese. Of course, you speak very good in English, but does your company provide any interpretation service?
Yes, we do. So we have the ability to get a translator on the line when we're talking to everybody in almost any language. And so we don't want language to be a barrier to couples getting the information that they need to make the right choices for them. So any language that any individual speaks, or even if people speak multiple languages, whatever language they're comfortable in, we can work together in that language.
Okay. Just now I saw that I reviewed one of the patient report that show us a sample report that you show us on the screen in your slides. And for example, in that slide, you show that embryo has diabetes. And for example, if a patient has multiple embryos, one of the embryo have the diabetes, another embryo have a higher risk of coronary artery disease, another embryo have another higher chance of hypercholesterol. Under this situation, and I still want to know among all these embryos, which one is a good option for me? Because I don't believe every embryo will be perfect embryo. So here and there, the embryo always has some mistake, just like us. We always have some mutation here and there. So do you have a good approach to a scoring system to tell me which embryo is the best embryo to be selected?
Yes, we're working on validating that right now, actually. So you're exactly right. When we are running the testing is going to help us identify embryos that are high risk for certain conditions or embryos within normal risk range. And so if you have a lot of samples with a lot of different data, how do we put all of that together? So one of the ways we're thinking about doing that is putting a genomic index score and attaching a score to the embryos so that it's easier for clinicians and patients to rank embryos in order to make a decision about what embryo they should prioritize for transfer. Now, certainly that index is important. What's also important is if there's any particular condition that's more worrisome, for example, to a particular couple. So, for example, we have a lot of couples who come to us because they already have a family history of type 1 diabetes, a child, for example, with type 1 diabetes. And so for them, type 1 diabetes is the most important condition that they're concerned about. They may be interested in the other conditions, but the most important piece of the puzzle for them is type 1 diabetes. In those cases, they may look only at that score and use that score to help triage and decide which embryo they should prioritize for transfer. So there's multiple different ways to look at the information. And what's nice about the reports is that we are putting and working on validating and studying that index so that we will be able to provide a simplified way of looking at the data, but all of the information is still there on the report so that if a couple is very interested in one piece of that data, that is available to them as well.
Okay, that's great. And I think that now we delivered a lot of genetic information to the patient, but I still want to simplify everything so that our patient can clearly understand what they're going to do. I want to give a roadmap about their roadmap about what they're going to do if they are interested in this service. For example, if you're a patient and you are interested in this service, and of course, we're going to arrange a genetic counseling with Jennifer. And after consultation, if we think this service is very important, and so the patient is going to collect saliva and mail the saliva to your company. And then we are going, meanwhile, they send consent. And here at New Hope, we're going to start IVF cycle. Either I or Dr. Jackman are going to do the egg retrieval for the patients. And after the egg is retrieved, we are going to fertilize the egg and culture the embryo step by step. And then when the embryo reach blastocyst stage, and then we do the biopsy, collect some sample. The sample will be sent to Genomic Prediction in New Jersey. And after 2 weeks, we are going to get the result. Oh, by the way, and the patient also wants to know if the result will show the embryo has a normal number of chromosome PGT-A when they get the report of a PGT-P.
Yes, absolutely. The PGT-P results are not useful unless they're paired with the aneuploidy screening results. So aneuploidy screening is very important because counting the number of chromosomes helps us give information about helping improve IVF success outcomes. And so if there's a chromosome issue, we're actually not even going to look at the PGT-P results because PGT-P results are impacted if there's too many or too few chromosomes. And the aneuploidy screening essentially trumps the polygenic testing. If there's an extra missing chromosome, we know likely that that would be an embryo that would not necessarily implant or be more likely to be a miscarriage or potential other significant health problems in an ongoing pregnancy. And so this information is important to be used together, and the polygenic testing needs to be performed with aneuploidy screening together. So that will always be included as part of that report.
Okay, let me clarify. And first of all, and you're when you get a sample, you're going to run PGT-A. That means you want to check the number of the chromosome. Even the embryo has a normal number of chromosome, you are going to check if the PGT-P for the embryo sampling, right?
Right. Everything is run together in the sense that in that 2-week period, we're going to do all of those things together. But that's exactly right. When the report comes back, let's say there are 5 biopsy samples that we tested. If 2 biopsy samples have extra missing chromosome material, that data will be on the report, but there will be no additional PGT-P data because that's not needed. And then for the other embryos that are euploid or have the usual number of chromosomes, you'll already have the aneuploidy screening and that information plus the polygenic testing altogether.
Awesome. Okay, Dr. Jackman, do you have any comments?
Yes, I wanted to know, do you also run PGT-SR for balanced translocations and PGT-M on the same sample with PGT-P? Are you doing any?
Yeah, we certainly can. So that's a great question. So for couples that have an increased risk of chromosome issues because one member of the couple has a chromosome rearrangement, or for families at risk for single gene or monogenic disorders, yes, we can absolutely include polygenic testing in their test plan. Everything is run on the same platform, and essentially, depending on how we interpret it, gives us all of the different ways we can utilize the information to report certain aspects of the testing. So yes, so for a couple that is at risk for a monogenic or SR condition or rearrangement, that couple doesn't have to be left out of polygenic testing if they're interested in that information.
And that would be one price. They'll pay one price of PGT-P and able to get all that information, or would it be different?
It would be one price.
Oh, that's good.
Wow, that's great. Okay, and of course, I know, and now your current PGT-P service will check the almost 10 health conditions such as diabetes or certain type of cancer. But in the future, are you planning to expand the service to more chronic condition or more polygenic condition?
Definitely. That's a big conversation in our laboratory all the time, is improving this testing. This testing is new, and the more we run this testing and the more people who have this testing and the more we study this test, the more information we'll gather and open the testing to more populations and open it to looking for screening for more diseases. So you're right, there's a number of different conditions that are available right now, like certain cancers and type 1 and type 2 diabetes, and certain risks for cardiac disease like coronary artery disease, heart attack risks, conditions like that. We hope to add certain things like schizophrenia, and other types of polygenic disorders. And we hope in the future we'll be able to continue adding to this panel of conditions that's available for screening.
And of course, we know New Hope Fertility Center will be the first center, or is the first center in New York State to provide this service. But I also want to know, does your company have any other successful rate in some other state for this service?
Yes, we have a number of different IVF groups around the country that have sent testing to us specifically for pre-implantation genetic testing for polygenic conditions. And there are a number of centers around the globe that are also interested in beginning to send samples for this type of testing as well. So it's definitely starting to grow, and we're starting to get many more people who are sending samples specifically for this type of testing.
Yeah, according to what I know, it seems that your company is the first company who provided this service in US, right?
Correct, correct. Yes, monogenic testing, aneuploidy screening, structural rearrangement testing has been around for quite a while, and there are a number of different laboratories that can provide that testing. And we certainly provide that type of testing and provide it very well. But when it comes to polygenic testing, that's quite new, and we're the only ones who are offering that type of screening right now. So we believe very strongly in research and studying and making PGT available to as many people for as many different things as possible.
Oh,
When a patient, sorry, when a
go ahead.
patient has a high risk test, is that, like, a lot of patients will ask this, I'm sure, but would that necessarily translate to unable to transfer the embryo? Or
Good question. It will not transfer. It will not translate to that. Because PGT-P is so different in the sense that it's different from monogenic testing. Monogenic testing, let's say a couple comes to us because they're at risk for cystic fibrosis, and we run testing for that condition. We're going to be able to say in that embryo whether that embryo is affected or unaffected with cystic fibrosis, for example. But when it comes to polygenic testing, it's very different. It's a screening tool. It's not a diagnostic test. So even if an embryo comes back as screening as high risk for a particular condition, depending on the condition, that still doesn't mean that that embryo is 100%, has 100% chance that they're going to develop that condition. It may be higher than the general population, but it's a screening tool. A way to be able to figure out which embryo should be prioritized for transfer. But we will not say on the report that that embryo should or should not be transferred. And even if you have this screening and you decide to use all of the embryos in the group of samples, regardless of what the test says, that's completely up to you and your choice between you and your physician. So we try very hard to make sure that this testing doesn't take away anybody's opportunity to transfer the embryos that they have available to them that they would want to transfer based on these results.
right.
All right, okay. And so Jennifer and Dr. Jackman, if you have no more questions, I'm very happy to pick up some questions from the audience. And I think my sighting is not perfect. Sometimes I cannot see the question from my own account, but I can read some of the questions from my cell phone.
Okay.
And the first question is, for the polygenic disease, how much genetic factors play compared to environment and lifestyle factors? Wow, this is a good question. Very scientific. Jennifer, do you
Yes.
want to answer this question?
Yes, that's a very good question. So it depends on the condition. And environmental factors certainly do play a role for many of these types of conditions. So for example, maybe less for type 1 diabetes, but certainly for high cholesterol, for example, we obviously know that diet plays a very strong role in high cholesterol. So all of these polygenic conditions are very much influenced by multiple changes in multiple genes, and then whether the disease actually occurs is then further influenced by environment, diet, all of these other factors. And so what we're not taking into consideration when we're running this test are the environmental pieces of the puzzle. We're very clear, for example, in our reports that that doesn't play a role. And that's okay, because again, this is not a diagnostic test. This is designed to see which embryos from a genetic perspective have a higher risk. And then that information can then be used in terms of transferring an embryo, but it's not going to tell us for sure, yes, we definitely expect this disease to be there or not to be there, because we can't do that, in part because we're not looking at the environmental piece of that puzzle. So that's a very good question, and it does it my answer is not so specific because it really does depend on the specific condition.
All right. Okay. I have one more question. And do I need to have a doctor's recommendation to be able to have this testing?
You need to work with a physician, a clinical team that has the ability to send samples to us and is able to send samples to us. So it's definitely something that has to be, we need a test requisition from your doctor. But we believe very strongly that patients should have their own autonomy in being able to decide whether a specific test is right for them. But that is definitely a conversation you need to have with your doctor in terms of, if this is something that's of interest to you, to discuss with them that this is of interest to you, and then they can contact us and send in that requisition so that you can start the process of counseling.
All right. The next question is, how much does the testing spend for a patient? I'm not sure if you want to answer this question or you want to leave this question to Lauren.
How much? I didn't hear the full question. How much?
How much does the testing spend for a patient? How much does it cost?
Oh, how much does it cost? That's a great question. It roughly it costs a couple $100 to test each biopsy sample, but the cost can vary a little bit. So it's important that you speak to your physician, and then we can talk about the specific cost during the genetic counseling session.
Okay, but I'm expecting your cost will be a little higher than the routine PGT-A test, right?
Correct. Exactly.
All right. Okay. And so one more question is from Han Yang. Okay, and she asks, what does polygenetic score mean to the patient? How does it change to our counseling and management? It seems this is a health provider.
So a polygenic risk score is a way of taking all of the data from all of the different genetic changes that are all along our genome. And so when we're running the testing, we're looking at the entire genome, all 46 chromosomes and 20,000 genes, and we're looking at a bunch of hundreds and thousands of different genetic changes all along the genome. And so when we're screening for polygenic conditions, certain genetic changes are more frequent in people that have these types of different conditions. And so we can add up all of this information, and adding up all of that information, we can define what's called a polygenic risk score. And that can be used to help determine which embryo has a higher chance of these particular conditions. And so the real goal of this screening is to help decide which embryo should be prioritized for transfer.
I see. Okay. And next question is from Eric, and he wants to know which disease can you screen again? Of course, and you have a video, but can you reiterate the list of the health conditions that you are screening?
Sure. So currently available is type 1 and type 2 diabetes. Certain cancers like breast cancer, testicular cancer, prostate cancer, certain skin cancers like basal cell carcinoma and malignant melanoma, and certain cardiac risks like coronary artery disease, heart attack risk, high cholesterol, high blood pressure. And we screen for idiopathic short stature and intellectual disability.
And Eric still have another follow-up question. And you mentioned that cancer can be screened, including the breast cancer. And he wants to know if it is the same as screening embryos against the BRCA1 or BRCA2.
Excellent question. Good question. No, it is not the same. So if a couple has a history of cancer relating to a single gene disorder like BRCA1 or BRCA2 or any of the other myriad of different single gene disorders that are associated with cancer risk, the best test and the most appropriate test for that couple is monogenic testing, PGT-M. Polygenic testing will not address the genetic change in that monogenic in that particular gene, okay, in the same way that monogenic testing will. So the most appropriate testing is monogenic testing. When we talk about other cancers being polygenic, we know that in some families, for example, even if that family tests negative for BRCA1 or 2 or other inherited forms of cancer, we still may see certain clusters of cancer in a family. And so that lets us know that there's maybe other things at play, other polygenic factors that are increasing the chance of cancer in that family. So we know that even in families where there isn't a known monogenic cause, those families still can have a higher chance of certain cancers, not to the degree of a family that, for example, has BRCA1 or BRCA2, but it can be higher. So polygenic testing is useful when people would like sort of a general risk of certain cancers in their family, or if they have a family history of cancer that is not linked to a monogenic condition. But in cases, again, where it is linked to a specific single gene, the best testing is PGT-M.
Jennifer, and just now I heard your answer. That's awesome. But still, I think sometimes for a patient or for audience, if they do not have any medical background, it's very hard for them to understand the monogenic and polygenic. Do you mind expand your explanation regarding this? What's the polygenic? What's the monogenic?
Yes, definitely. So monogenic conditions are conditions that occur because there's a specific change in one gene. So we have 20,000 genes in our body that all have different functions. Conditions like sickle cell anemia or cystic fibrosis or Tay-Sachs disease or BRCA1 or 2, all of those are examples of single gene disorders. You just need a genetic change in one gene to cause that disease. Okay, so that could be because a person has a condition and potentially could pass it down to their child, or if both members of a couple are carriers of the same genetic condition like sickle cell trait, they have a risk of having a child with sickle cell disease. That's monogenic conditions. Polygenic conditions are different. Polygenic conditions are disorders that are not caused by a single change in a single gene will not make a polygenic condition more likely, but multiple changes in multiple genes. Each individual one isn't so important, but the effect is additive. The more changes we have associated with heart disease or certain cancers or type 1 or type 2 diabetes, the more that could push us forward to developing that condition. And so polygenic testing is screening for all of those different genetic changes to come up with this polygenic risk score. Polygenic conditions are worldwide are more common than single gene disorders or monogenic conditions.
All right, okay. And Jennifer, I saw the slides you play in the bottom of the screen. It looked very attractive. Do you mind give us more explanation about these slides?
Sure.
You are muted.
Thank you. Thank you. So I'll start again because I didn't know when that all of a sudden that happened. So to the left of the screen, you can see the different the movement, and those are the little circle plots that we have on all of our reports to show if there's any added or missing chromosome material. So the second one, in the embryo in the middle, has a chromosome issue. It has a little red line. It's hard for me to see from this distance even with my glasses, but there's a chromosome issue in that embryo. The first one, the last one are what we call euploid embryos. And so to the right of that is all of the information that we include on the report for polygenic testing. So there will be a specific risk percentile for the different conditions that are included on the panel, and it will say whether that's considered normal risk or high risk. And what is important to know is besides the risk percentile, that information shouldn't be used in a bubble. The risk percentile for that particular embryo should also be used in conjunction with, well, what's the average risk in the population? So saying a risk is 30%, let's say for a particular condition, that's nice to know, but is that normal? Is that not normal? Well, it helps a lot if we know that the general incidence of that condition is 30%. That means that that embryo's risk is expected to be exactly what we would expect in the population. We would call that normal. But if the average risk is 5% and the embryo's risk is 30%, well, obviously that's much, much higher. So we want to make sure that we give a specific risk percentile for the majority of the conditions on the panel, as well as give you the information so that you compare that to what is the average risk. And then the other numbers are there to help you see, well, how far from the average is that risk? And the percentile on the very end, on the further right side, will let you know, is this in the 50th percentile, which is totally average? It means 50% of embryos will score higher and 50% of embryos will score lower. That means it's exactly in the middle. Or is it in the 98th percentile, meaning, oh, this embryo scored almost the highest, and the vast majority of embryos will score lower. That would be a more high risk number. So information is there to help give you not just a specific risk for those specific conditions, but help you have additional information to put those numbers in perspective.
So the actual risk will be on the patient risk.
Yeah, the actual risk will be the risk for each embryo biopsy, each embryo.
Oh, and it's very impressive from the 3 clips of the embryonic development. From these 3 clips, we can see all of the embryos reach blastocyst stage. However, and from the genetic study, we know some of the embryos have a normal number of chromosomes. Some of the embryos have a higher risk to have diabetes. It seems that we cannot make a judgment on the embryo only from morphology or from their dynamic change. And I know that now a lot of centers are using AI technology to help make a judgment from embryonic morphology change to help us to make a decision about the quality of the embryo. It seems that based on our genetic information, and the AI technology will give us a support, but not adequate. All right, and I have one more question, and so I cannot see from my screen very clearly, and for that question, okay, but I can see from my cell phone. It said, okay, it's a PGT-P need ethical approval. Do you do PGT-P? I cannot see the full question. That's from Xiaoyun. Oh, do you do PGT for autism?
Good question. No, autism is not included on our panel right now. That's something we're certainly thinking about and working on in terms of adding. We have intellectual disability on our panel, but intellectual disability is not synonymous with autism. And so we need more data in order to add autism to our panel. And we are very careful. That's something that we do. We don't add conditions until we have enough validation and enough information to be able to add each individual trait to the panel. And so it takes time to add that. So currently, no.
But does the PGT-P need ethical approval?
No, it does not need ethical approval. This is a test that is available in the United States clinically, and so it does not need any extra or any different type of approval compared to the usual PGT tests that are available.
Oh yeah, by the way, I just want to make a comment since I'm working in New York.
You're muted.
Sure, if we're hearing you.
Mm-hmm.
All right, okay. Since I'm practicing in New York, and I know that when I submit a request, I have to submit a waiver to New York State. Do you mind to tell the audience the reason?
Sure, sure. So New York State has very different, each state has different rules in terms of whether samples can be sent to particular laboratories. So we're CLIA and CAP approved, and we have all of those approvals, and we're in the process of getting specific New York State approval. So until that occurs, New York State requires a specific form for each patient to be able to approve each case individually. So it's not an ethical approval or anything like that. It has more to do with the way New York State operates in terms of which laboratories can clinicians can send samples to. So fortunately, the process of getting New York State approval on an individual basis is very, very simple. And a form is sent in, and then they review the form, and then everyone that's been sent in thus far has been approved, which is great.
Awesome. Okay. Dr. Jackman, do you have any comments?
Well, I just wanted to ask two questions that patients typically ask, and I'm sure you'll get a lot of these questions too, is, I mean, could you test, you mentioned that you can test for intellectual disabilities for it. Could you test for something like IQ to see how intelligent you assume the future child would be? And the follow-up question is, could you test for like hair, color, eye color, different physical attributes
Great.
in the embryo?
Yeah, that's a great question. So no, the goal of this testing is truly to help inform about embryo health. And so we're not screening or including any physical traits like hair and eye color and things like that. And as far as intellectual ability or IQ, that's also not something that we're screening for. So we are screening for intellectual disability, which falls for us along the same lines in the same way that aneuploidy screening also screens for intellectual disability related to chromosome issues. Certain chromosome issues are associated with intellectual disability. So this, in this sense, it's a different type of test, but it falls from an ethical perspective along those same lines. But we're not screening for intellectual ability or any other traits because that's not related specifically to health. And that really is the goal of this test, is to help inform about certain factors related to health issues so that parents, potential parents and intended parents can make decisions about transferring the highest priority embryo for them.
Okay. Excuse me. I hope I have no COVID-19. Okay. So I have one more question for the audience. What's the purpose for PGT-P? Number one, for example, the third embryo on the slide will develop breast cancer at 99%. If this embryo is transferred, the kid will be stressed for his or her whole life.
Good question. So the question is really how to use that information in terms of embryos that are transferred. And so there's different ways to think about this information. For couples that know no matter what that they would transfer any embryo regardless of the results of the polygenic testing, then polygenic testing for that couple or family is not necessarily the right testing for them. For other couples, having this information, even if they were to transfer an embryo that's high risk for one of these conditions, can then be used to inform their healthcare provider, depending on what the disease is. So for example, if it's a condition that occurs more frequently in childhood, like type 1 diabetes, they can inform their pediatrician. And if it's more adult onset conditions, this information can then be used once a child reaches adulthood to inform all of the medical decision making that can also help improve our health if we have a higher risk of breast cancer, in the same way that testing for BRCA1 or BRCA2 can do. So increased surveillance and all of those other types of things, and having that information be shared with their clinical provider at that time. So there's different ways this information can be useful. And that's the important piece, is that everybody has different views and different feelings about what information is useful to them. And that's why it very much, the decision whether or not to have this testing very much falls in the hands of not so much the clinician, although the clinician is part of it, but really the couple and whether this information is helpful to them or not.
Well, and there's another similar question like last question, and Eric wants to know, every content like this. This sounds like people would want to know all kinds of stuff to choose the best kids. Is there anything that's illegal for you to tell?
That's illegal for us to tell? Not on this panel. So there's nothing on that. We try very hard to create a test that really does use information that is informs health. So there is nothing illegal about any of the information that's included on this test, as the test is presented in the clinical way that we're providing it right now.
Yeah, I think that this is always a concern, or this is always an ethical argument, just like when we just started IVF. And probably in 1978, when we just started IVF, a lot of people are challenging our physician role to challenge the role of God. And I don't believe that we really want to challenge the role of the God. In another word, we are thinking that God sent us to the world to help the rest of the people. And of course, the more we know, the more confusion or the more future we're going to know. This is really a double-bladed sword. And for example, if for an embryo, we know the embryo have a lower chance to develop diabetes or hypertension, this is really good news for the kids or for the family. But it doesn't mean that the kids in the future can abuse his life and can her life, and to make her or himself to have a higher risk to develop diabetes. I think that this, if we just give a sort of sorting, and probably by this sorting, we can lower the cost for future medical care. But it doesn't mean that we are going to get rid of the disease. It doesn't mean that we can let spoil the child.
Exactly. This testing does not guarantee 100% health. Nothing does. And this is not designed to do that either. That's absolutely true. And it is true that if you look at the past history of PGT, every time there was something new, it was always debated. With good reason. We should debate the new tests that come as a group, as clinicians, to discuss them and make sure we understand them in the exact right way. But for example, you know, when screening, when ability for us to do PGT-A was brand new, and all the conversation centered around sex selection, and oh my goodness, and now this is very common in the United States, for example. And then it was, oh my goodness, we can test for monogenic conditions, but we should only test for things that are affect children, let's say. And now we have the ability and are routinely doing testing under a monogenic platform for conditions that are adult onset, like BRCA1 or 2. That's very, very common. But many years ago, that was widely debated. So it is true that there's always going to be a debate around new tests and around new technologies. That debate is not a bad thing. It's a good thing. We should always discuss the benefits and the limitations and the right ways and the wrong ways to use all of the new technology that we have, but it's not unusual that there's also discussion around this testing, because now this testing is new, you know, and as this, it will be very interesting to see as this test becomes more commonplace in 5 years or 10 years or however many years, it'll be very interesting to look back at this time and see what we were talking about now versus, you know, how the comfort level for people in the future.
All right. Okay. We have one more question from RE physician in Stanford, and she's asking which ethnicity data was used to calculate the risk.
Wonderful question. That's a great question, and ethnicity does play a role. There are certain the data was culled and validated from data from the UK Biobank, so from European Caucasian ancestry. And so the majority of conditions that all of the conditions that we're able to test for, we know we can screen and are very well validated in individuals with that ethnic background. There's less data available that we use to validate from other ethnicities. So we know, for example, for individuals that have Asian ancestry, we've been able to validate 4 of the different diseases that are currently available on our panel. That we hope to change that, and that is also part of the testing and the studying that we're doing in the laboratory, is that the more data we have, the more we're able to validate, not just in a single population, which is not our goal, but to make this available across all populations.
Okay, awesome. Okay, we're going to see if I have more questions from the audience. If there's no more question, and we're going to probably have your Lauren to make the to next step to have raffle. Let's see if you have more questions. Okay, I did not see more questions. Lauren, are you here with us?
Yes, I am.
All right.
Sure.
Okay.
We can do a raffle.
Okay.
All right, let me.
Do you want me to tell me something about your company, and tell us something about yourself?
Sure. I'm the CEO of Genomic Prediction. Working with Jen from the start, and this has been a real pleasure to hear you 3 talking about this. And Dr. Liu was talking about a raffle. So what this means is everyone who's participated in this seminar, who has answered at the beginning or will answer at the end, they want to participate in the raffle, they're going to be chosen amongst at random, and 3 of them will be given a free genetic test for PGT-P if they do participate with New Hope to undergo PGT and IVF at New Hope Fertility Center.
Okay, awesome. Hope you can start. I don't know what's your criteria to start your raffle. Nobody gets a raffle ticket.
Oh yeah. So we can't do it on the webinar right now because there's no way to do that. So we'll have to when people they leave the webinar or when they will have had the chance to type in yes, I'd like to participate, and when they leave, they'll have the chance to do that again. And if they want to participate, then at the end, we're going to be doing this raffle at a future time. And then we're going to notify the person who's won that they've won the raffle. And maybe we'll make an announcement on our website as well.
How are you going to inform the patient? Probably have no time to check your website. Are you going to email them?
Yes. So if people want to participate, then they will have given us their email address as a way of contacting them again. And then we'll email them. Exactly.
All right. I think today we talk a lot about the PGT-P, but in the future webinar, I'm very happy to talk deeper regarding the scientific background and the rationale for this test.
Well, the background and the origin, polygenic risk scores are a field that's gone back more than 10 years from now. But it's only very recently that this has become a popular concept in the common mind. I think it's fair to say that it's becoming a buzzword now, polygenic risk scores. A lot of people have heard of them, but we've been doing this research for more than 10 years now. This is a very old idea, actually. Some of the first people to talk about PGT-P, the concept, were Steptoe and Edwards, the originators of IVF, way back in 1995. Steptoe published a paper where he was talking about this was where IVF would inevitably go And he was a very smart guy. He was proven correct more than 25 years later.
Okay, great. All right. And I think that if we have no more questions, and probably we can conclude this webinar. Bye. Thank you for your listening.
Bye.
Thank you,
Good
everyone.
luck.
Thank you so much.
Bye-bye.
Bye-bye.
Bye.
So, there's nobody.